Good afternoon, everyone. My name is Dova Levin, and I am the Senior National Director for Educational and Patient Programming. And we are here today to talk about knowing your antibodies. We have Dr. Sri Muppidi with us. Dr. Muppidi is a neurologist affiliated with Stanford Healthcare at Stanford Hospital. He received his medical degree from Osmania Medical College, NCRUHS, and has been in practice for more than 20 years. Dr. Muppidi has participated in many MGFA events and conferences, including the San Francisco Health Fair Regional Conference, as well as our scientific session and international conference. We do want to thank our sponsors today, our national presenting sponsors, Alexion, Argenx, and UCB, and our national sponsors, Horizon and Neuroscience. Okay, I'm going to stop sharing, and I'm going to ask Dr. Muppidi to share his slides and to go ahead with the presentation. And we will be doing the Q&A at the end of the session. You can put your questions into the Q&A box, and we will try to get to as many as we can. All right, Dr.
Great. Good
Muppidi.
afternoon, everyone, and good evening for those who are in East Coast, and whatever time it may be if you're watching this at a later point online. My name is Sri Muppidi. I'm a neurologist at Stanford. Myasthenia is one of my clinical as well as research interests. And this topic about knowing your MG antibody or knowing your antibody for myasthenia gravis came up during my own clinical practice. Many of my patients, who I naturally assumed know their antibody well or know their disease well, had reached out to me not knowing or not sure about their antibody status, which was sort of an eye-opening. I just assumed that everybody knew. And over the years, there's been such a dramatic development in therapies for myasthenia that, and a lot of these are dependent on your antibodies. Our approach to treatment is evolving based on the antibody. And so one of my passion projects is sort of patient advocacy and helping them figuring out the best way to approach their disease and manage their disease. And if you have myasthenia, one of the best ways you can advocate for yourself is to know the type of myasthenia, the type of antibody you have, because as you will see, a lot of the treatments are based on the antibody. So these are my disclosures, similar to some of the things that were sponsored for the MGFA events. I've done advisory board for a few companies. I've had some grant support from MGFA. I will discuss a couple of therapies that are not necessarily FDA approved, but are used in clinical practice. So I'll go through a few questions as an objective for this session. Hopefully we'll meet all of these by the end of the session. So, and again, I just wanted to emphasize that this talk is really directed for patients. I'm thinking of some of my own patients in my clinic. When I'm talking to them in clinic, how am I approaching the disease? How am I explaining it? So I apologize if some of you, and likely many of you, are really well versed with the disease and you feel like, well, this is kind of, I already knew all of this, so bear with me. The talk does get a little bit more advanced. I'll give you some overview on additional developments, but I will start from a very basic idea. So we'll talk a little bit about what is an antibody, how do specific antibodies cause myasthenia, and then why do you need to know the antibody, apart from the fact that I say it would be good to know your antibody. So one of the questions that usually comes up when we see patients in practice that I usually get asked is, patients ask me, why me and why now? Why did I get the antibody disease now? And why was it not before? And did I do something? And so this is a really challenging problem. A lot of the times if I'm seeing with a spouse, the spouse might feel like, well, he did this and that must have caused it. It's never really that simple. But there are a number of reasons why it happens. There could be some genetic predisposition that some of us might have that later point develops into a disease. There might be some epigenetic reasons. There might be environmental reasons like your microbiome, your exposure to other environmental factors. Occasionally, various therapies might lead to the disease itself. And so a lot of the times patients have some predisposition to the disease. There might be some benign autoimmunity. Over a period of time, this might evolve into definitive disease, and hopefully with treatment, things are in a better shape going forward. And so naturally the question comes up as to, okay, well, you have an autoimmune disease, but we need immune system for something good. It's not just to cause an autoimmune disease. And a lot of us learn sort of in high school, for example, that immune system has two different components to it. There is innate rapid response immune system, and there is an adaptive slow response immune system. The innate rapid response is the one that when you're exposed to a pathogen, virus, bacteria, these are various cells in your body, white blood cells, types of white blood cells that attack the pathogen, that attack the virus, the bacteria, so that you don't have a significant infection. Apart from attacking it, they also recall or remember the antigen or the source of the problem on the virus or the bacteria. And that leads to sort of communication with the B cells. B cells are the cells that produce antibodies, and they lead to production of the antibodies. These antibodies stay in your system, and the next time you get exposed to that particular virus or that particular bacteria, or that particular pathogen, the antibodies the next time can directly attack, and so that you don't have such a severe disease manifestation like the first time, for example. And so this part, the adaptive part, takes a longer period of time. But the challenge, of course, is that these antibodies can sometimes attack your own body, and that's what causes an antibody-mediated autoimmune disease. There are non-antibody-mediated diseases as well, but we'll stick with, for this presentation, antibody-mediated diseases. So these Y-shaped structures are what we are looking at. These are the antibodies that are produced by the B cells. And so one of the this is, if you, again, going back to sort of high school learning, you might have seen this structure. This is a Y-shaped structure. And there are two components to it. There is a region on the top of the Y, which actually binds to the antigen or the pathogen, for example, or the target of the antibody. And there's this region called the FC region, which actually helps it recycle in your bloodstream so that this particular antibody, the IgG antibody, has a half-life of about 21 days or so. And one of the reasons is that this FC region allows it to recycle in your own bloodstream, unlike other types of antibodies. The antibodies are the immunoglobulins. There are many different types of immunoglobulins. They go with A, D, E, G, and M. We'll stick to G because most of the pathogenic antibodies, the antibodies or autoantibodies that cause disease, are IgG related. The myasthenic antibodies are definitely IgG related. Within the IgG, there are different subtypes, IG1, IG2, IG3, and IG4. That might not be as relevant for some of the conversations, but some of the myasthenic antibodies are IgG1 and 3, and some of them are IgG4, and that might become relevant as we go through the conversation a little bit more. And so one of the questions that usually comes up as I'm sort of talking to my patients in practice about this and autoantibody production, the natural question is, well, why did those antibodies get produced to begin with? They're there to fight against infection. How did those antibodies start attacking my body? How does that happen? And so, again, there are many different reasons, many different explanations for it. One of the common explanation is that there is a trigger factor. Something happens that triggers your body to produce these antibodies. And so these could be change in your microbiome, like we talked about it, environmental factors. This could be you got exposed to a virus. There could be a tumor in your body, for example. All of these can stimulate antibody production. And there is sort of that particular antibody that's produced as a response to these can have effects on the neuromuscular junction or on the muscle membrane and lead to myasthenia gravis. But these antibodies can attack brain, spinal cord, nerve, muscle. And so there could be a gamut of different diseases based on the antibody that's produced, based on the way it attacks the body. Of course, there are autoimmune diseases beyond the neurological system. There could be other reasons for having it. Sometimes our body loses tolerance, or our ability to sort of decide, body's ability to decide, oh, this is my own body, I'm not supposed to be attacking it, loses that tolerance, and that can also lead to antibodies. Sometimes newer cancer immunotherapies essentially work by removing that tolerance so that your body can attack the cancer cells, which is great. These drugs are remarkably effective. However, one of the complications of that process is that when the body suddenly is able to attack the cancer cells, they also produce additional antibodies that can attack other organs. And one of the complications of cancer immunotherapy can be myasthenia. You can have de novo myasthenia because of the cancer immunotherapy, or if you have known myasthenia, that can definitely get worse. So this pathway is complex. We don't quite know for an individual patient what it might be. Sometimes we see after they had a tumor that they had a disease, so we have a sense of what that might be. If they suddenly took cancer immunotherapy, we know why that could be the case, but we don't always know for an individual patient why all of a sudden they developed these antibodies. And within the nervous system, obviously nervous system is diverse and there are lots of different structures that can be attacked, but the specific ones that are relevant for this conversation is what we call the peripheral nervous system, which is nervous system that starts from the spinal cord. There are nerves that come out, and then the nerves meet the muscle, and that's called the neuromuscular junction. Many of you already know, if you're listening to this conversation or participating in MGFA event, that the neuromuscular junction is where the problem is in patients with myasthenia, and there are diseases where muscles are also affected. But we will stick to the neuromuscular junction disease, specifically for a disease, myasthenia gravis. There is another autoimmune disease called Lambert-Eaton myasthenic syndrome, but for today's conversation, I'll just stick to myasthenia gravis. So this is where the antibodies attack the muscle membrane, prevent the sort of signal transmission from the nerve into the muscle, and that's what causes the weakness. There are many phases of myasthenia. I like this slide because it kind of shows the gamut of problems that one might experience in myasthenia. For example, this patient has eyelid drooping or ptosis. This patient has weakness of the facial muscles. This patient has weakness of the forehead muscles, atrophy of the tongue, not able to close their eyes completely. For example, this man has significant drooping of both eyelids, and he uses his hand as a way to sort of keep one eyelid open. You might look at a patient like this and think, oh, they're really paying attention, which they might be, but they're also using that as a strategy to keep their eye open so that they can actually have a conversation or see things well. But there are things that happen beyond myasthenia gravis. So this is a patient of mine who gave me permission to play his speech problem. So the patients have speech problem, patient can have difficulty speaking, swallowing, chewing, weakness in their arm or neck muscles, or difficulty getting up from a chair. And a lot of these symptoms can be fatigable, by which we mean as the day goes by, they get more weaker. Or as you keep doing the function, one might experience even more weakness. So for example, this patient, I asked him to count from 1 to 25, and he will count from 1 to 25. I want you to quickly listen how the speech changes as he's counting from 1 to 25. Well, I'll play it one more time so we can listen it twice.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
So as he was counting from 1 to 25, you saw that at the beginning, when he was starting with 1, 2, 3, it was very clear. As it got up to about 15, 16, you notice that speech was different. I'll just play that component one more time.
3, 4, 5, 6, 15, 16, 17, 18, 19, 20, 21, 22, 20.
And so that's a very fatigable component. That's what we mean by the weakness can be fatigable as you're doing a function it can be problematic and can get worse. And that can be experienced just not beyond speech. As you're eating, for example, after a few bites, you might feel like you can't chew well. Or after taking a few steps, you might feel weaker. Or after brushing your teeth for 30 seconds, you might feel like your arm is getting tired. Or as you're looking up, your eyelid is drooping further. So we use all of these symptoms and figuring out, is it fatigable or not in clinical practice to diagnose myasthenia. So how do we diagnose patients with myasthenia? So we look at the clinical picture, we hear the story as to what's going on with them. And then once we suspect that somebody might have myasthenia, we do various tests of fatigability, just like the patient who gave me permission to play his video of his speech. We can do the similar test for drooping of the eyelids, for example. We can also do a test called ice pack test, where you put a ice pack over the top of the eyelid and then see if it recovers well. So those are all help you suspect myasthenia. And then we do antibody testing. These are all commercially easily available testing. The most common antibody that you test for is the AChR antibody, and generally takes about a week, 10 days to come back. A lot of the times, a lot of the labs reflexively test for MuSK antibody if the AChR is negative, but if it's not, you would send it again for MuSK and LRP4. These are the two other antibodies. So if they have the AChR antibody, their diagnosis of myasthenia is confirmed, you can move on to trying to treat them. If the AChR antibody is negative, we check for additional antibodies, MuSK, LRP4, and then I'll talk a little bit about one additional assay called cell-based assay. If those are all negative, then we do some physiology testing, essentially trying to prove that there is a problem from signaling from the nerve to the muscle, and that's causing the fatigue, and that's what the physiology tests do. And if they show abnormalities, again, the myasthenia is confirmed. If all of these tests are negative, then the likelihood of it being myasthenia is low, and certainly, and if you have ongoing symptoms, we should consider other diagnoses, and that's what we do in practice. And so the antibody testing, first one we do is the AChR antibody, the acetylcholine receptor antibody. Second one is the muscle-specific kinase antibody. Third one is the LRP4 antibody. These are all tested in the serum. And so when they take your blood or the serum, they look for different analyses like ELISA or Reaper techniques to radioimmunoprecipitation assay to look for those antibodies in the serum. Now, but there is another way of doing the same antibody testing, perhaps a little bit more sensitive. It's called cell-based assay. We currently do the cell-based assay if the routine antibody tests are negative. Cell-based assay essentially means that when they take your serum, they cross it with a cell or the fly cell, which can attach to the antibody. The antibodies are present, and then detect them. A little bit more technically, obviously a bit more challenging. Previously was not routinely commercially available, but I know at least one lab in US called NeuroCode, where they're offering the cell-based assay. And they have already published some data that assay is a little bit more sensitive than some of these patients who were thought not to have an antibody or we never found an antibody. When you do the cell-based assay, we find an antibody. Now, there's a very small percentage of patients who, when you do all of these things, still don't have an antibody, but they have myasthenia, that we have proven that they have myasthenia. We call them seronegative, as in no antibody at present that is detectable. The thinking currently is that they still have an antibody. We just don't know how to detect it yet. What about the physiology testing I had mentioned? We do two different physiology testing. One is called repetitive stimulation, which is exactly what it means, that you get repeated stimulation of the nerves, and then you record from the muscle. So we do it at different sites. So there is ulnar nerve, which is on this side, or median nerve here, spinal accessory, which is a nerve in the neck area, and we record from the shoulder muscle, or we stimulate the facial nerve and we record from the nose muscle up here. All of these, we stimulate the nerve and record the signal. And essentially, if the patient has fatigue or weakness, we are able to see that reduction in response. So for those who are interested in physiology or find this sort of thing fascinating, it's not the most pleasant of tests. I've had it myself, colleagues, trainees to practice on me, but it's definitely tolerable. And so here is, for example, an example of a repetitive nerve stimulation that is abnormal and diagnostic of myasthenia. So here is the first stimulation, and you can see there's a nice response. And so think of the height of this structure or this shape, and then as you had more stimulations. And as you can see from the first stimulation, the height of this, and after 4 or 5 stimulations, how much it has dropped by. And this degree of drop is about 40-some%. That degree of drop is abnormal. And we did it after a brief exercise. There is a little bit of an improvement in the degree of drop, but then the degree of drop comes back. Again, here the degree of drop is 57%, then 50%. And so this degree of drop is abnormal. And we look for this drop. And this drop is consistent with the idea that if you keep doing a function, like that patient of mine who was counting, for example, and as he got up to 15 or 16, the speech became slurred. That's what exactly we are trying to prove by a physiology test. And so this is a fairly sensitive test, but it has to be done in a muscle that's actually weak. If you cannot find this pair of nerves and the corresponding muscle that's weak, it might be difficult to tell. And so there is even more sensitive test called single fiber EMG. Specialized test has to be done in a specialized center, or somebody who's done a lot of them. Here, there's a signal of the signal is coming from the nerve, just to sort of show you a picture of how this particular single fiber EMG test runs. Signal comes through the nerve, goes into the muscle, and the muscle contracts. And so what happens is that there's a small needle that is inserted into the muscle, and the end of the needle records from a very small area. And so essentially, the needle records from 2 different muscle fibers that are firing when the patient activates the muscle or contracts the muscle. And so if this whole part, the nerve muscle junction and the muscle, if all of them are working well, then the 2 pairs will fire in coordination to one another. So like this case, for example, it is a normal 2 pairs of muscle fibers that are firing, are activated. And if you combine them all together, we call it rastering, put them on top of each other, you will see they essentially match. But in a patient with myasthenia, for example, there might be some variability because the neuromuscular junction is not working well. So sometimes there could be variability in when the second one fires in relation to the first one. And so that variability is called jitter. And here we would call it increased jitter. That's a feature of a neuromuscular junction problem. Occasionally, sometimes the second one doesn't fire at all, or it's dropped out, and that we call it blocking. That's also a feature of a neuromuscular junction dysfunction. And so if the antibodies are negative, then we can do single fiber EMG or repetitive stimulation to diagnose myasthenia. And so some of you might have had these tests. If you already had the antibodies that are definitely positive, you don't necessarily need the test. And so I talked a little bit about the diagnosis, some of the testing that's done, but I didn't talk about the sort of the basic science behind it. And so I'll spend a minute or 2 on this slide because this is critical that this part is understood for to follow along with the next part of the presentation. So here is a nerve terminal. This is where the nerve meets the muscle. So this is the end of the nerve coming here. This is the muscle on this side. And this area in between is called the nerve muscle junction, where the nerve meets the muscle. So when a signal comes through the nerve, it releases the chemical called acetylcholine. This is the chemical we're talking about, these purple balls. They go and bind to the receptor, acetylcholine receptor. So think of it as a vesicle. It comes and binds to it. That causes changes in the muscle and makes the muscle contract. This happens billions of times, of course, in our body, and none of us have to even think about it or worry about it. And as long as this is going well, there should not be any problem. The key issues is 1, this is the acetylcholine receptor. These receptors are all clustered together, as in come together. So when the acetylcholine binds, they can cause a significant contraction of the muscle. There are a few other proteins across the muscle membrane. One is called MuSK. We were talking about the MuSK antibody. Another one is called LRP4. another protein here. And these become critical because there are antibodies against these structures, and that can also cause the disease. And so how does disease happen in myasthenia? We were talking about the acetylcholine that comes in, binds to the receptor. But if you have the acetylcholine receptor, for a minute, we'll just talk about the acetylcholine receptor antibodies, which are these red-shaped, Y-shaped structures. We talked about how antibodies are that Y-shaped structures. They can bind to the acetylcholine receptor, and they can cause problems with the signaling of the acetylcholine. So if you cause damage to the receptors, and when the acetylcholine gets released, it has no way to communicate well with the muscle that can cause muscle contraction. How does it cause the problem? There are a number of ways it causes the problem. One, it can block to the receptor. It can bind to the receptor and block it so that the acetylcholine cannot bind to the receptor. It can bind to the receptor and sort of internalize it so that it's not available for the acetylcholine to bind on the surface. And the third pathway, which is also a critical pathway, is that it activates a protein called complement. Complement is a critical rapid responsive immune response that can fight against bacteria, for example, but it can sometimes autoimmune diseases also activates complement. And this complement protein can deposit on the muscle membrane and cause something called membrane attack complex, which causes damage to the muscle membrane and again, impairing the transmission. Whereas with MuSK antibodies, it binds to the MuSK antibodies here. And then I'll talk about a little bit at the end of this presentation, how the MuSK antibodies cause signaling problems from the acetylcholine into the muscle. Myasthenia, there are many subgroups. There is early onset, late onset. So if you had it early in the life, late in the life, if you had purely eye symptoms, if you have myasthenia associated with thymoma. A lot of these, thymoma is associated only with acetylcholine receptor antibodies. A lot of the early onset, late onset, again, are in the picture of patients who have AChR antibodies. There are patients who have MuSK antibodies, LRP4 antibodies, and a small subset of patients who are seronegative, as in we currently don't know what antibody they have. Beyond the subgroups, there are other associations, as I talked about, associated with other autoimmune diseases, associated with thymoma. Sometimes myasthenia can happen in the context of different therapies. But going back to the physiology or the reasons why you get the disease with AChR antibodies, for example. So we talked about how the antibodies attach to the receptors and cause damage different ways. It can internalize the receptor. It can block the receptor so the acetylcholine cannot bind to it. It can cause activation of the complement, and that causes damage. So those are the three main mechanisms that we know that acetylcholine receptor, how it causes myasthenia in disease. And this slide is important because beyond what I'm showing you at the neuromuscular junction, the antibodies themselves are produced by B cells, and they are in turn stimulated, related to T cells. T cells come from the thymus, for example. And so there are mechanistically, the whole process of production of the antibodies and how they cause the disease are sort of depicted in this picture. One of the common agents we use is the acetylcholinesterase or mestinon pyridostigmine, for example, that increases the amount of these red dots, the acetylcholine, at the neuromuscular junction. So with that background, let's think about how the drugs that we use in myasthenia, how do they work? How do they make a difference? So the acetylcholinesterase inhibitors therapies, for example, improve the amount of acetylcholine, which is great, which certainly is helpful. When you don't have as many receptors, you can increase the amount of acetylcholine that can help transmitting the signal. That's good. But you need something a bit more specific. You need to make sure that these receptors are not getting damaged. And so because this is antibody-mediated process, you need more specific immune therapy to make a difference there. And so we have oral immunosuppressive therapies that we use, prednisone, mycophenolate, Cellcept, azathioprine or Imuran, few other agents. They work on the B cells and T cells. We have short-term immunomodulation, things that can rapidly sort of reduce the antibody levels, for example, IVIG, plasma exchange. We also have therapies that are purely B cells, like, for example, rituximab. But for a long period of time, we hadn't had therapies for complement, and now we do. And so they certainly make a difference because of that. And as you think about how we approach disease based on how the antibodies are causing the disease. So if you reduce the antibodies by either suppressing the B cells or reducing the stimulation from the T cells, you can certainly reduce the antibodies here. But it wouldn't affect the complement unless you do something for the complement pathway. And so that's the critical part of understanding how the disease is caused so that you can attack it based on where the problem is. So complement pathway is here, right here. The antibodies, the AChR antibodies, induce complement activation and cause deposition of the complement. And so until recently, until a few years ago, we did not have any complement therapies, but now we have 3 agents. First one was eculizumab, which is a monoclonal antibody. It's given intravenously. After a loading dose, it's given every 2 weeks. And you will see that patients, here the blue is the drug. Once they're started on the drug, their symptom scores dramatically improve compared to red is placebo across a spectrum of different measures like myasthenia gravis activities of daily living, quantitative myasthenia gravis score. You'll also see the degree of improvement. We call these Christmas tree patterns. And so here you will see the blue is the drug group, red is the placebo group, those who did not get the drug. And you will see that the degree of improvement is much higher, those who got the drug versus those who did not get the drug. And so eculizumab is FDA approved for AChR positive myasthenia gravis. There's another drug called ravulizumab, which is essentially sort of a longer acting version of eculizumab. It's given every 2 months. Again, here the blue is drug. You will see the symptoms dramatically improve after starting the therapy compared to the red dotted line is the placebo. In the Christmas tree pattern, again, here the blue is the drug. You will see a lot more improvement in symptom scores in ADL, QMG compared to placebo. Ravulizumab is also FDA approved for patients with AChR positive myasthenia. And the latest one is called zilucoplan. This one is given daily subcutaneously. And this is, again, shows you the improvement in their symptom scores pretty rapidly after starting. Again, the Christmas tree pattern showing that patients who had the drug had much higher rates of improvement in terms of level of improvement with different metrics. So that's one of the reasons why we use complement therapies in patients with AChR myasthenia, because we know from the basic science side of things that the complement is activated by AChR myasthenia. What else can we do apart from this? Could we reduce these antibodies here? So there's these antibodies that are being produced. Could we reduce them quickly? So if you don't have as many antibodies, there should not be as much damage to the receptor. And so there should be better signaling from the nerve to the muscle. And so this is where the newer line of therapies that some of you might have seen on TV or heard about them online or various seminars are called FcRn therapies. You might recall right at the beginning, I had shown you that the bottom Y is the Fc part of the antibody. And so that's where that nomenclature comes from. And so we know from treatments like plasma exchange, which is where they take your blood, filter it, and give it back to you. So the plasma is exchanged out. We know that with those treatments, you can reduce the immunoglobulin levels rapidly. And when you reduce the immunoglobulin levels, you reduce the antibody levels. And patients do get significantly better from plasma exchange. Unfortunately, plasma exchange is a procedure. It requires an IV line. Some places you have to be hospitalized. Some places they can be done as an outpatient, but certainly is a challenge, not as easy to accomplish, not every time. And so could we do this chemically? Could we give a medicine which could mimic this reduction in immunoglobulins? Because we know antibodies are essentially Ig immunoglobulins. And if you were to have a similar response, could you have improvement in symptom burden? And so that's where these FcRn antagonists come into picture. These are drugs that impair the ability of the immunoglobulins to recycle. Like a lot of things in the body, there's a lot of homeostasis, there's a lot of reserve in our body. And so the immunoglobulins get recycled. And one of the reasons they have a half-life of 21 days compared to other immunoglobulins, the IgGs, is because they get recycled. So the FcRn drugs essentially prevent that recycling so that they get degraded and your immunoglobulin levels reduce. When your immunoglobulins levels reduce, naturally your antibody levels reduce. And if your antibody levels are lower, we saw from the picture earlier, your symptoms should be lower. And so there are multiple drugs that are approved and already being tested, efgartigimod, rozanolixizumab, nipocalimab, for example. All of them have been tested at different doses. They all reduce your immunoglobulin levels based on the dosing and the regimen. And this led to further studies. And one of the first FcRn drug that was approved is called efgartigimod. Again, you will see here the blue is the drug. And so rapid decline in symptom scores compared to the red is the placebo. And if you go back to the Christmas tree, much higher levels of improvement with the blue is the drug compared to red placebo. Similar findings were also noted with the second drug that was FDA approved called rozanolixizumab, which is given subcutaneously as an infusion. Again, much more improvement with the drug compared to placebo. And so these drugs reduce the immunoglobulin levels and then reduce the antibody levels. After a period of time, the drug wears off and the immunoglobulin levels will come back. Not every patient, the symptoms come back. Some patients' symptoms are steadily stable. Sometimes they do come back and you might require more infusions based on how one responds to it. But a lot of these drugs, these two drugs, the efgartigimod is available as an intravenous drug. It's available as a subcutaneous drug. The rozanolixizumab is available as a subcutaneous infusion. Again, these drugs are approved for patients. The efgartigimod is approved for patients who have AChR antibodies only. The rozanolixizumab also included in their study some patients with MuSK antibodies. So it's also approved for AChR and MuSK antibody patients. We briefly talked about the MuSK disease and how it might be different from AChR at the beginning. So some of you might have noticed that AChR is here, MuSK is here. So how does an antibody here cause a problem with the AChR? Because that's where we all sort of looked at the picture earlier. The acetylcholine comes and binds to the AChR, and that's the critical part. And so what happens here is that it's slightly different compared to what happens with AChR receptor, AChR antibody myasthenia gravis. MuSK are these proteins here, and they also are sort of four of them form together with another protein called LRP4. There is another chemical called agrin that's released by the nerve terminal. When that comes and attaches to these MuSK proteins, all these four of them come together. That causes further phosphorylation changes in the muscle membrane, which leads to these acetylcholine receptors all coming together. Being together is the critical part. When they are together, it's easy for the acetylcholine to come and join or attach to it and cause muscle contraction. If they're not together, then it's not as effective. And so in patients with MuSK MG, essentially the antibodies are against the MuSK, or if they have LRP4 against LRP4, for example. And so when that's affected, they are not able to come together. They're not able to cause other changes in the muscle membrane, and they're not able to lead to the clustering or coming together of the acetylcholine receptors. And that's the critical step that's missing in MuSK MG. Unlike the AChR MG, where there is complement activation, other treatments that are based on the complement activation, in MuSK, complement activation is not a key component of the disease. And so that's one of the reasons we don't use complement drugs for patients with MuSK MG. We use other treatments which purely reduce the antibody levels as an effective strategy for MuSK MG. MuSK MG is slightly different from AChR MG. They can have a lot more sort of weakness of the face or throat muscles or respiratory muscles. They can have a much more rapid progression of the disease, for example. Early treatment is crucial because if you have these symptoms that are undetected or undiagnosed or not treated, you can even have atrophy of certain muscles, including atrophy of the tongue muscle, for example. And patients who have MuSK-MG usually respond well to steroids or prednisone. They respond well to a drug called rituximab, which is a B-cell drug that reduces antibody levels. They also respond well to plasma exchange, which again filters out the antibody. As I mentioned earlier, rozanolixizumab is FDA approved for MuSK. I have not used it in my practice yet for MuSK-MG, so I have no experience to share. Paradoxically, and I did not get into this, pyridostigmine, which is commonly used in AChR positive patients and effective, perhaps not completely, but does help to some extent, is not as effective in MuSK-MG. And then rituximab has been shown to be dramatically effective. A lot of the clinicians around the country and across the world use rituximab early in the course of MuSK-MG with dramatic improvement. And so this is where it becomes critical to know the antibody, because the choice of drugs might be quite different based on which antibody you have. And so why do you need to know the antibody? Hopefully I convinced you that you need to know your antibody. The main reasons are there are many newer therapies that are currently FDA approved for AChR positive myasthenia. And so if you don't know your antibody, it becomes a challenge for you to advocate for yourself. If you're struggling with your symptoms, when you go and see your doctor, it's critical that as you understand what's happening in the field and what's changing about myasthenia treatment, if you know your antibody, you can sort of take the steps to advocate for yourself the best you can. The treatment paradigms are not the same. As we talked about, the treatment paradigms for AChR myasthenia includes complement therapies, FcRn therapies. Well, the treatment paradigm for MuSK patients are quite different. In our practice, we end up using rituximab whenever possible early in the disease course because it makes a dramatic difference to many patients with MuSK-MG. The last one is we don't quite know the true incidence of seronegative MG in various studies because the awareness of what the exact antibody that a patient has is unclear. And so this is reflected by many studies. I just wanted to point out that MGFA runs a wonderful registry, and it's been a resource for many researchers. And I took the data from one of the publications in 2019 here for about 60 some patients who were either unsure or did not know what their antibody was. And this is in reflection to a study from Europe, for example, from 2 hospital centers. This is a study reported by the physicians, not by patients, where out of the almost 200 patients, 84% of them had AChR antibodies. So almost certainly, many of these patients who were unsure or did not know what they had, definitely had this antibody. And to me, if you know this, you can advocate for yourself much more strongly, much more robustly. And that's where I feel like it's critical to know your antibody, especially as the field has evolved so much with so many new therapies, which are all going to be dependent on the antibodies. The reason they're dependent on the antibodies is that the antibody, the way it causes disease, varies based on which antibody you have, AChR, MuSK, LRP4, seronegative. Your ability to participate in a clinical trial also depends on that. So hopefully I met some of these objectives we kind of started with, but I'll just quickly go through them. We talked about what is an antibody. It's part of an immune system that we all have to fight against pathogens, bacteria, viruses. But there are autoantibodies that can cause disease. Myasthenia is probably the most well-known example of that. How do specific antibodies cause myasthenia? We talked about how AChR antibody causes myasthenia. We talked about how MuSK antibodies causes myasthenia, and they are different. And treatments are also, as I pointed out, slightly different in terms of the drug choices that we use and the testing that we do. Why do you need to know antibody? I hope I convinced you it's worthwhile. Treatment options definitely depend on the antibody. Association with thymus-related pathologies. So if you have a thymoma that's frequently only seen with patients with AChR, antibody, not necessarily with MuSK. So there is that difference too. And hopefully, if you want to participate in a clinical trial, if you are looking to contribute to science in other ways through online surveys, it's critical that you know your antibody. I would encourage you, if you already haven't done it, and I should have done it at the beginning of this presentation, take 5 minutes, sit down after this talk, and look at your own medical records. You might already know your antibody. Great. If you don't know your antibody, write to your doctor or talk to your doctor. Don't write to your doctor, all of you at the same time, because your doctors will reach out to me and say, hey, Sri, buddy, cool it. But next time you see them, reach out to them and try to find the antibody that you might have. I want to just finish by one announcement by one of the researchers, Dr. Kaminsky, who some of you know has presented to this forum many times. Well-known researcher. They are looking for patients who have MuSK myasthenia who are willing to donate a saliva sample. They're trying to do a genome study. So we're talking about how autoimmune diseases have genetic basis. And so they want to look for any particular genetic associations. So they require a lot of samples. Everything is completely protected. None of your private information will be released. And so you can either look up online on the MuSK 1000 sms.gw.edu, or you can contact the research team at that email, or you can call the research team at that phone number, and they can share more information. Thank you so much for reaching out to them. I think I will stop there and take any questions.
Thank you so much, Dr. Muppidi. By the way, Meredith stepping in here. Unfortunately, Dova lost internet connection, so y'all are stuck with me today. And for those who don't know me, my name is Meredith. I am the Assistant Vice President of Patient Engagement. So always happy to be on. And Dr. Muppidi, thank you so much. Such a phenomenal presentation. And as I mentioned to you earlier, you know, I get these questions a lot, or, you know, one of the things that I ask patients when I'm talking with them is, do you know your antibody type? And if not, that's okay, but, you know, let's help you advocate for yourself and give you the right tools and resources to have that conversation with your doctor. And you laid it out so beautifully. So thank you so much. We have a lot of questions, and I'm going to try to get to most of them as best as I can, maybe even combine a few. So
Sure.
Give me a second to read a little bit here. Okay, so this question kind of goes hand in hand with a couple of questions, but the question is, so if you tested positive for AChR, you know, many, many years ago, is it worth being retested like in present day, especially if you feel like you're experiencing whether it's no symptoms or symptoms at all? I guess, you know, the question also to that question, it's like, do antibody levels, are they associated with the severity of symptoms?
So great question, by the way, obviously a very sophisticated question. If you were to take 100 patients, check antibody in 100 patients, and look at the symptom burden in 100 patients, from what we know, the antibody levels in the 100 versus the symptom burden in the 100 doesn't quite correlate. But if you take a single patient, check their antibody levels, and then longitudinally see them over a period of time, when patients' symptoms are better, usually the antibody levels are lower. And so with certain treatments, for example, mycophenolate has been proven when you treat them for a long period of time, it definitely leads to reduction in their antibodies. In practice, when I see patients, they've had a previous antibody, they have known myasthenia. If they're essentially symptom-free or not having any active symptoms, I don't repeat the antibody because it wouldn't change what we would do for you, the fact that you're doing well. If you're all of a sudden having more symptoms, then we do check the antibody. Mostly out of scientific curiosity, has there been a sudden increase in your antibody levels? Should we repeat a CAT scan of your chest, for example? Or if the antibody levels has dramatically gone up with lots of these newer therapies, which we know can rapidly reduce your antibody levels, that might become an option. And so those are the reasons I would check it, especially if your symptoms have suddenly become worse. If you are not having any symptoms, I'm not sure it will add much.
Gotcha. Okay, that makes sense. So I guess, the following subsequent question to that is, like, if you're checking for the one antibody maybe that you've identified, do you check for other antibodies in patients? Like, say they have AChR positive, like, are you checking to see if they have MuSK or LRP4? Or better question, can you have more than one antibody if you have myasthenia gravis?
Oh yeah, wonderful. So we don't routinely do it. There have been anecdotal reports, small reports here and there that some patients have more than one antibody. I have not routinely tested it. Occasionally, if I have taken care of a patient, their antibody is positive, but their disease pattern is different. For example, if I have an AChR positive patient, but they have having a lot of difficulty with their speech, a lot of difficulty with their swallowing that I'm not able to treat well or not able to control well, then I might check it. But it's very rare that we would currently do multiple antibody tests in a same patient. A lot of the testing paradigms that offer testing for the antibodies essentially are reflex testing. So they check the AChR. If you're negative, they check the MuSK automatically. But if your AChR is positive, they don't automatically check MuSK, because having two antibodies is, we think, very rare.
Good to know. Very good to know. So we have a lot of seronegative questions, and I'll try to address them as much as I can. I think a lot of people are interested in the treatment options for seronegative patients. I mean, other than prednisone, how does your treatment approach when you're managing someone who is seronegative?
Seronegative. So pyridostigmine or mestinon, first choice, obviously. We use prednisone if we are able to do. We also use all the oral immunosuppressive agents, mycophenolate, Cellcept, azathioprine, Imuran, so on and so forth. Occasionally, the symptoms are really severe. I have used IVIG. Rarely we have tried to use things like the complement inhibitor, even though they're seronegative, for example, but it's a challenge to be able to use them. Certainly would be using them completely off-label. FcRn therapies, I have not used them in seronegative. It's a challenge because the field is definitely moving forward with lots of therapeutics available, but they have not yet translated to seronegative. And I can see how the seronegative patient population find it so challenging. The reason partly is that in clinical trials now, they are trying to include seronegative patients, a small number for every time they do a AChR positive patient, to get a sense of it. A lot of us believe, even if you're seronegative, there is an antibody that is likely causing the disease. We just don't know how to pick up that antibody. We don't know how to detect that antibody or prove that that antibody is causing the problem. I'm hopeful eventually, with so many therapies that are in the pipeline that have been recently approved and are being tested, there will be additional options. There are additional treatment trials for other T-cell mediated therapies that are likely going to definitely be an option in seronegative patients, because they're not directly affecting the antibody, they're affecting higher up in the pathway, for example. And so there are definitely therapies in the pipeline, but it is true that the AChR patient population has a lot more options right now.
Right. So staying on seronegative patients, so if a seronegative patient was in an MG crisis or an emergency situation, and when they're asked, or first of all, are they ever asked about their antibody status? And if they are, like, how do you advocate for yourself, I guess, in those sort of very intense situations?
Yeah, so if a seronegative patient is in crisis, we treat them like we would treat any crisis, which would involve treating with IVIG or plasma exchange. Certainly, we look for antibodies. If there is sort of doubts about the diagnosis, you can have things like repetitive stimulation that are very, very sensitive for a patient in crisis because their muscles are significantly weak. So the repetitive stimulation should clearly be abnormal. So there shouldn't be as much of a doubt about the diagnosis. But unfortunately, the treatment options for any of the patients currently, if you have crisis, tend to be the three things that we have always used: steroids, IVIG, and plasma exchange. There have been anecdotal reports, and we have also used complement therapies in patients who have really refractory crisis that is not improving in spite of those agents, but those are only anecdotal, have not been formally tested.
Okay. Oh my gosh, we have so many good questions. It's hard to pick. And Dr. Muppidi, if you see any that you would like to address that are more suited, by all means, please feel free to.
Oh, sure. Yeah, I'm also looking. So there is a question, I didn't address this, by Amy. Speaking of LRP4 positive patients, there seems to be some debate and confusion among neurologists about LRP4. Specifically, is LRP4 positivity diagnostic of MG if a patient also has negative single fiber EMG? Wonderful question. I wasn't sure if I should get into the weeds so much. There is some challenges with LRP4 because that particular antibody has been reported with other types of neurological disorders, nerve disorders. So it might not be truly specific for myasthenia. If you had a single fiber EMG at a very good place by a physician or a faculty who is very well experienced, it's done in a muscle that's weak. And if that single fiber EMG is normal, then I don't think the LRP4 is diagnostic. Because single fiber EMG, as I showed you, where it looks at those pairs of the muscle fibers, that if you are weak in a muscle because of problem with the neuromuscular junction, that pair firing, the jitter, the blocking should be abnormal. By definition, they should be abnormal because that's how we think the physiology works. And so it's worthwhile rethinking about the myasthenia diagnosis in that very unique, specific situation.
Gotcha. Okay. Great question.
There was one, sure. Yeah, very challenging.
Go ahead, Dr. Muppidi. I am trying to prioritize as much as possible, but I kind of want to give you that sense of agency to decide because there's so many good questions.
Sure. There is one, again, I should know, advanced audience, obviously. There's a Kevin, late onset myasthenia gravis, AChR positive, 60% relief with Ultomoris. Again, for the audience, Ultomoris is ravulizumab. Comment on changing to zilucoplan and FcRn to attack on two pathways. And so again, I picked this question because it kind of fills in and goes into the depth of what I tried to cover. And Meredith, next time I give this, I'm just going to get into the weeds pretty quickly. Because obviously this audience loves everything.
Seasoned people here.
Yes. So I think for the rest of the audience, what Kevin is trying to ask here is that we talked about how the AChR pathway has a complement and then the antibody reduction strategy, for example. So with the efgartigimod or Vyvgart, these medications which reduce immunoglobulins, when you give them with other monoclonal antibodies, then the monoclonal antibody level also goes down because the FcRn drug prevents sort of the monoclonal antibody levels. And so the new drug, the zilucoplan, which is just got recently approved, it's a peptide. It's not a monoclonal antibody. While it blocks the complement pathway. So that could potentially theoretically be used along with an FcRn therapy. And the levels should be okay. They should not be they shouldn't be working against each other. And the question is, could they work synergistically and give you a lot more symptom relief? Theoretically, yes, Kevin. I have not used that combination. Unfortunately, in clinical trials for these drugs, for the zilucoplan clinical trial, if you were on efgartigimod, you couldn't participate in the clinical trial. And obviously for the efgartigimod clinical trial, if you're on zilucoplan clinical trial, you couldn't participate in this one. So there might not be any data for that combination. But could we envision in some patients who are struggling with the combination with one of the drugs, like for example, Ultomoris, and could we come up with this kind of combination? Possible. One caveat is that these are all new drugs, at least the FcRn drugs for sure. And so we don't know regarding the safety profile of adding these two new drugs in a single patient, the risk of infection. Does it also go up dramatically just because you're adding two drugs that are not being studied in combination? But there might be a handful of patients that will have that combination. I hope my colleagues at national level write their experience if they were to have them, so that we all can learn from them. Yes, great question.
Great question. So unfortunately, we're out of time, and I know we have so many questions. So if you are interested in following up, please feel free to reach out to me, and we can, try to address those questions. I also wanted to mention, which I think is very pertinent to this discussion, is we've been talking about seronegative patients, and as you know, we have our patient registry, which I think both Dr. Muppidi and I can't emphasize enough how incredibly critical it is to contribute your experience and to demonstrate your lived experience with MG by adding your data to the registry, because that will really help inform clinical trials and research moving forward, and hopefully one day more and better improved treatments for not just AChR patients, but seronegative and MuSK patients and LRP4 and all the other antibodies that haven't been discovered yet. So if you have the opportunity, please go check out our registry. And yeah, so Dr. Muppidi, thank you again. This was so wonderful. And again, if anyone has any questions, please feel free to follow up. And yeah, look forward to seeing you soon, Dr. Muppidi. So thanks again, and take care, everybody.
Yeah, thank you all. Thank you so much for having me. And thank you, Meredith. And like most things at MGFA, thank you, Dova, for making it happen.
That's right. That's right. That's right. Thanks again,
Take care.
Dr.
Have a
Muppidi.
wonderful
Take
evening.
care. You
Bye-bye.
too. Bye-bye.